Should I start now? Dr. Agarwal Sahab, should I start now?
Yes, please go ahead.
Sir, this is Amresh Tiwari. You know that I am editor publisher of Double Helical Health Magazine. This is monthly health magazine being secretary of Delhi NCR region. Today's topic is very mind-blowing. Patient safety and health policy its implementation. जैसा कि आप जानते हैं कि हम लोग तमाम पेशेंट सेफ्टी में बातें करते हैं और तरह तरह के इसमें क्वेश्चन भी आते हैं, लेकिन डॉक्टर जैसे विजय अग्रवाल साहब हैं, डॉक्टर ज्ञानी साहब हैं, मदन गोपाल साहब, डॉक्टर अमिताभ हैं, मैडम सुनीला गहे, सारे एक्सपर्ट हैं. वी हैव द गैलेक्सी ऑफ एक्सपर्ट. बट जो पेशेंट के जहन में जो भी बातें आती हैं उनका ढंग से सेटिस्फेक्शन हम नहीं कर पा रहे हैं, उनका जवाब नहीं दे पा रहे हैं. तो आज हम कोशिश करेंगे कि हम पेशेंट के हितों की बात करते हुए है कि हमने ऑडियंस को कैसे सेटिस्फाई करें. तो इसके लिए आज हमारे साथ जो हमारे मॉडरेटर हैं वो हमारे मेंटोर डॉक्टर अरुण अग्रवाल साहब, प्रोफेसर ऑफ एक्सीलेंस, एक्स डीन ऑफ मौलाना मेडिकल कॉलेज, करंटली ही इज द मेडिकल एडवाइजर इनोवेशन क्लिनिकल रिसर्च अपोलो ग्रुप हॉस्पिटल. एंड हमारे साथ ये जो डॉक्टर विजय अग्रवाल साहब, ये अपनी फील्ड में बहुत ही एक्सपर्ट है. ये ही इज ए प्रेसिडेंट काहो. And Dr. Sunil Agar, he is a chair program advisory committee, Ministry of Institute of Health, Ministry of Family Welfare, New Delhi. And Dr. Girdhar Gyani Sahab, he is a Director General, AHPI, yani Association of Healthcare Progression, New Delhi. And Dr. K. Madan Gopal, he is a Senior Public Health Expert, Advisor, National Health System Resource Center, former consultant in Niti Aayog, and Dr. our most learned Dr. Amitabh Bal. He is a public health expert, Professor Emeritus, DY Patil Medical College and Research Center, Pune. Now I just hand over to Dr. Agarwal to moderate to the webinar. Thank you, sir. Thank you.
Thank you, Tiwari ji. I think we are going to have the second part of our discussion on patient safety.
Yes.
And last couple of weeks back, we had the discussion, which was very useful. But this is perhaps the continuation and very important aspect of patient safety, that is the implementation. When I start this webinar, today morning I read the newspaper, and I'm sure some of you must have read one of the newspaper which has got very important headlines. Infection from medicine tube in Indian hospital is very high. Outcome of a study. This, whenever we read this thing, we feel sad. We feel that something perhaps we are not implementing in an appropriate manner. I remember that we started talking of patient safety in early 2000s, and after that, a lot of discussion was held, and the outcome of that discussion, as regards Ministry of Health is concerned, all my experts will remember, Dr. Madan, that it was launched in 2018. NPSIF provides a comprehensive policy framework to integrate various national health programs and strategies under one umbrella. And those programs includes the National Health Mission, Clinical Establishment Act, Adverse Event Following Immunization, Pharmacovigilance Program of India, and Hemovigilance Program, etc. So that was the 2018, and then Government of India tried and working on its implementation. And perhaps we'll talk about implementation, the progress, and let us see what is more to be done So thank you very much, Tiwari ji, for giving us this opportunity, a very important aspect. And I always say Double Helical is a magazine which is perhaps coming out with something which is useful not only for medical fraternity, useful for every member of the society. This is one of them. So when we talk about the national policies, I'll start with Dr. Vijay Agrawal. That there was a framework which was declared by Government of India, and I remember I was also part of it sometime, and then even WHO was part of it, and so many experts. Where do you think, Dr. Vijay, we are as regards its implementation is concerned? I'll come to my other colleagues also. Dr. Vijay.
Just one, give me a minute, sir. Just 1 minute.
No.
Wait a minute. Thank you, sir.
Dr. Vijay Agrawal is totally dedicated for the cause of patient safety. He is the initiator of a movement called KAHO. And they're approaching not only within country and all over abroad in different part of the globe. So we feel proud of you and your.
Thank you, sir. Thank you for all your kind words. You're able to hear me?
Yes.
Yes, sir.
All right. So, sir, first of all, my reaction, first of all, I also must congratulate Tiwari ji, Double Helical, for bringing out this aspect of, talking about this aspect of patient safety, and that is on the policies and of this kind. Because this is where most of the times the people who are making the policies, they make the policies, and often they are forgotten in the drawers or somewhere along the line. So when you open the door in which you can call it a go down of policies over the years, you find fantastic policies globally. And it's not merely that we are talking about India. What you read in the newspaper today is again nothing new. And the quantum of medical errors is well known. So that's not an issue. It's today a global problem. And this global problem has been in existence in spite of huge number of, I will say, protocols and policies, both globally. For example, in as well back as 2003, we had come out with a universal protocol where there was a standardized surgical safety checklist, mandatory timeout before surgery to prevent the wrong site or wrong patient surgery. But even today, it happens. There was a WHO Patient Safety Alliance in 2004, which raised global awareness and introduced the clean care is safer care, promoting hand hygiene. And again, we know that this is far from universally being implemented. Then medication safety regulations. And then as what you are talking about, that even in our country, we have had, you see, I think in the year 2010, pharmacovigilance program in India, which was to definitely contain the issue of culture of drug safety. Just 1 minute. And sorry, there was a call.
Yes, Vijay.
Yes, just 1 second, sir. There was a call that came.
No problem, please.
I had to. Yes. So this, then there was a national health initiatives under the National Health Mission standards, such as the National Quality Assurance Standards, and NQAS, various it was like another parallel to the NABH for the government organizations. Then we had the National Health Policy of patient safety in critical care area. A number of policies have been there. I think the issue what we have to probably examine is why is it that these policies remain on paper? So even a very important project like a World Patient Safety Day, which is celebrated on 17th of September every year, for example. And we did a survey of about, let's say, 100 medical professionals. And you realize that 90% did not know even the existence of, there is something known as the World Patient Safety Day. Everybody knows the Valentine Day, but they do not know the World Patient Safety Day. They do not know that the various themes which have been, and all those themes, whether it was medication safety without harm, or elevating the patient's voice, or this year it is on the pediatric age group. So organizations like ours, we do our best to run with those kind of initiatives, to take out to various hospitals, you run with it. But what we realize is that the penetration is only amongst the, at the moment, the quality managers, the administrators. They start knowing something, they start doing and giving some feedback, yes, that this is happening. It's more like a tick box, those are happening. The real people, the clinicians, the nurses, etc., there has to be a far greater awareness of these policies. These policies are of no value unless or until a leadership will start recognizing the impact of these policies on the ground root. So the major problem, there is number one, no dearth of policies. I mean, if you will look at all the policies which have been framed so far, I don't think any area has been left which has not been addressed. And that's something that is of, I will say, a great concern for us, which leads us whether we need to bring medical education, we need to have more, I will say, icons who should be leading. We need healthcare leaders. For example, I will say that all these specialty organizations, they should be talking about some of these policies and the patient safety issues in their annual conferences. But they all talk about their domain expertise. We talk about our advancements, but we are not taking seriously this issue of patient safety at any level. The people who are making the policies, they are very happy making the policies. But somewhere along the line, they don't have the responsibility to see those policies are implemented on the ground. So I don't know. I mean, it's like a Pandora's box, sir. I'll come back again to you, but I'm sure that people like Dr. Madan Gopal, Dr. Sunila, and others are much more tuned with the policies. But as far as we are concerned at CAHO, we are very, very concerned, and we are working very hard to see that they get implemented.
Thank you. Thank you, Dr. Vijay. I fully agree with you that there are policies being framed at the highest level, and the best of the brains are working on it. But India is a big country. Implementation, it starts from top and then it goes down and down and down to the peripheral level. And the monitoring of all these are important. So now, as you mentioned that we have to do something, I'll now go to our colleague and friend, Dr. Madan Gopal. Dr. Madan Gopal is the person who had been associated for this activity at Niti Aayog, the umbrella organization for the country, the biggest think tank. And now he is at NSRC, another think tank for Ministry of Health. And we will like to hear him. Dr. Madan Gopal, what do you think is the status of the implementation? And okay, let's talk about the status and how to improve it so that we don't get headlines like that, which I showed you in the morning newspaper.
Thank you, sir. And thank you, Vijayji, for highlighting the important policies which we are having. And we should appreciate that we have moved from awareness to policy adoption on patient safety. But the real challenge is implementation at scale and creating a culture of safety and ensuring patients themselves become partners in this journey. This is a very important thing because what we have seen over the years, as you have rightly mentioned, that we have more or less all the experts, they talk about patient safety, but we are not been able to ensure that the patient themselves become partners in this journey. That's a major area which lacks in the implementation. Having said this, one of the important things, as sir, you have already been mentioning that we have a very comprehensive framework in the global south. That's the National Patient Safety Implementation Framework, which was started in 2018, and you were associated with that. And it is till 2025. That means it's the right time that how we think that the patient groups and the patients, they also become partner to this so that collectively we can take it forward. As mentioned by Dr. Agarwal and Vijayji, saying that national health policy is there. Beside that, in IPHS 2022, we were previously following the Bureau of Indian Standards for our health facilities. For the public facilities, now we are having evolved from the 2007-2012 Indian Public Health Standard, which talks about exclusively of patient safety. Besides that, different programs do exist pharmacovigilance. It's just a repetition. So we have the right policy intent and the institutional structures, but the implementation has been very uneven and fragmented. If you look at the public sector, there are many central programs. We do have labor room quality standards, the PM Suman program, which we are trying to ensure having a Surakshita Matvata Ashwasan. The assurance has been given by the government side. Kayakal program is there, which have all been scaled up. For example, more than 2,000 facilities are certified under Lakshya certification for maternity safety. But more is to be done. If you talk about the FRU setup, we have around more than 6,000 community health center where delivery happens, where you would be having labor room. Where is that assurance and the quality standards for that? If you talk about the private sector, which is also largely fragmented, National Accreditation Board for Hospital, they cover around out of the 7,000 all hospitals, how many of the hospitals they are accredited? Around 1,500, 2,000 hospitals. But if you look at the adverse disease reporting system, it has grown, but device-related and surgical error reporting systems very weak and underutilized. Besides that, there are state-wide variations, sir, regarding the implementation of this. States like Kerala, Tamil Nadu, Gujarat have stronger patient safety cultures, infection controls, hospital accreditation, while many other lack. Implementation is patchy, sir, with progress in islands of excellence, but not universal. If you talk about the public sector, NEP, this NCOS certification also, that's also very patchy. And still after 10 years, we are also struggling to see that more and more people, they come out to this. But besides that, having an accreditation, that's one thing. Is it translating into patient safety? That's another question which we need to ask. But we have to see that the culture of the patient safety in India is required thing is still developing. Underreporting of medical errors is widespread due to fear of litigation or blame. Safety is often treated as compliance audit requirement, not as a core value. We have to bring the core value into the patient safety. Limited patient involvement in patient safety committees or hospital governance. The only representation in the form of the elected representatives who are not at all bothered about the taking the plight of this. We're still in the transition from a reactive blame culture to a proactive learning culture. That's the thing which we have to build. If you talk about the comparative with the global standing, we are far ahead with many of the South Asian neighbors in terms of policy framework, but very behind the OECD countries in implementation of patient engagement. This is the challenge. That means we do have policy intent in place, but once it comes to implementation, the lot of challenges are there. The patient harm rates in India are estimated to be around 8 to 12% of hospital admissions, similar to global average. But preventable adverse events are higher due to weak reporting and IPC compliance. COVID-19 has shown both strengths, rapid IPC scaling, oxygen safety protocols, and weakness. That is there. We are at the mid-level, progressive in policy, lagging in practice compared to other states. But we do have opportunities, sir. We do have Ayushman Bharat digital mission, which can improve safety through e-prescription, error reporting, error reduction, and data-driven risk alerts. One Health and AMR action plan is in place, which integrates human, animal, and the environmental safety aspect. The National Medical Commission reforms. Patient safety is added into the medical curriculum. Besides that, in Ayushman Bharat, this hospital, empaneled hospitals, we have linked insurance with the patient safety. The institutions which are NABH and NCOS certified, they are given more incentive as compared to the other thing. But there are many gaps which needs to be addressed for achieving that thing. No national patient safety reporting or learning system is yet to be evolved. It is fragmented under PVPI, MVPI, but we need to have a reporting and learning system which is inbuilt into that. We do have limited trained workforce, infection control nurses, safety officers, biomedical officers. The state level action plans under the NPSIF are still pending in most places. The consumer awareness is very low, and often the patients are unaware about their rights and safe practices. In short, to summarize, we are having policy ready, but implementation is challenge stage. We are policy ready, but the implementation is in the challenge stage. The progress is visible in maternal safety, cleanliness, and pharmacovigilance, but lot is desired to be done in other areas. The systemic culture of challenge, workforce training, reporting system, patient empowerment are the missing links. With ABDM and Ayushman Bharat, India has a historic opportunity to mainstream patient safety into the very fabric of health systems. Sir. So this is the implementation and the challenges which I could see that a lot of work is to be required, and we have to ensure that patients themselves become partners in this journey of patient safety. Thank you very much, sir.
Thank you, Dr. Madan Gopal. I think you have given very clear picture of various aspects where the government is trying their best, but ultimately government, different institutions are there to form policies, their efforts to implement it. But ultimately implementation is within the hand of those who are working at the periphery. As Vijay also said that perhaps among that group, there is lack of knowledge, lack of awareness. But I like to say that Rome was not made in a day. Our efforts have started, and perhaps it will take more time to perhaps achieve the perfection. I'll go to now Dr. Sunila Garg. About her, I say, you must have heard Lady with the Lamp. So here is Sunila, who is the lady with public health achievement for our country, even globally. So Sunila will like to comment upon the implementation of various parameters in relation to, and what is your view on it?
Thank you, sir. And thank you, Dr. Vijay, Dr. Madan, and most importantly, Amrish Kumar Tiwari ji for having me there with you. I think this is a very, very important topic because in morning only I was listening to Dr. Paul when he talked about, malnutrition, and particularly in context of children and so many problems, big country with big problems. But sir, when you talked to me, and when you told me, it took me back to about 20 years back. If you remember that we were equal partners, and under your guidance at Maulana Azad Medical College, we started postgraduate fellowship in HIV medicine. And what was unique about postgraduate fellowship in HIV medicine was each candidate was asked to prepare HIV control action plan at their workplace. So most of them, they talked about, medication safety, they talked about, hospital infection control, and 3 institutions for all of you, those who are not aware of this fellowship was between CMC Vellore, Maulana Azad Medical College, and School of Tropical Medicine, Kolkata. So each of the candidate prepared their own action plan, which was shared with their own health authorities, and SOPs were prepared for implementation. And along with that, it was not only a kind of a research project which involved the candidate, which involved the organization and its implementation, but also it talked about involvement of patients, which both, Dr. Madan has says at a greater length along with Dr. Vijay Agarwal. So I feel that it is so very important that when India is a big country with 36 states, union territories, along with, when we talk of, nearly now we are talking of 780, districts. And plus, so we have to talk now of the district action plan and its implementation, because we cannot ignore our private partners. So we have to talk about involvement of private partners as well, and which has got to be everywhere. Now we are talking of skill-based learning. So that part is very important. And also when Dr. Madan mentioned about patient engagement, I still remember last year when I lost my brother, because of liver tumor. But the important part was the central line, which always I was telling the doctors that it has been 2.5 months since you have put the central line, but ultimately it ended up with fever and all. It was not a, a hospital it was a hospital in tier 1 city where, the oncologists were looking after and all that. But, that is where each one, because the patient is subdued, patient has no voice. So that is where we need to talk about, patient engagement, which is very, very important part. So along with that, we have to have building of safety culture right from Ayushman Mandirs when we talk of, and there was a mention made by Dr. Madan Gopal, we need to talk right from CHCs, involvement of CHOs, ASHAs, or, when we talk about, because they are our messengers of change. So ultimately, we have to talk about strengthening of all systems. That part is very, very important, and we have to integrate this safety into all aspects of healthcare delivery. So whether we talk of hospital infection control, or when we talk of medication, reducing medication errors, or when we talk of adverse events following immunization, everything has to be implemented as a common package in a common manner at the systems platform. And another part is that we need to talk about equity, inclusiveness, and compassion. When we talk about empowerment of patients, क्या हमारे patient की voice है? Can he or she talk? Because ultimately, despite empowerment, we say कुछ आपको तकलीफ हो तो बताना, but we don't qualify that तकलीफ. We have to see that हमारा patient कितना empowered है, because every time डॉक्टर टॉक सब ठीक है, बट वी डू नॉट टॉक अबाउट आपको टाइम से दवाई मिली, आपकी ट्यूब चेंज हुई कि नहीं हुई, कैथेटर चेंज हुआ कि नहीं हुआ. सो दैट पार्ट बिकम्स वेरी, वेरी इंपॉर्टेंट. सो आई विल से दैट बेसिकली वी हैव टू बिल्ड हाई रिलायबिलिटी systems along with, safe clinical practices, which should have audit both in government and private sector. That part is very important. So we have to see that ultimately, do we have I'll say that the issue in place which inspires and strengthens the health workforce capacity, because ultimately what has to inspire our healthcare workforce, that will be the capacity building with skill-based training. That part is important, and we have to have reliable indicators. That part is very important, and ultimately each one of us has to think of how we can invest in research, innovation, and technology for safety. So that part is very important. So I'll put my voice to rest at this point of time, and we'll talk when you go further in the discussion. Thank you so much.
Thank you, Sunila. I think very importantly, you have given the description of various aspects and the ground reality you have explained. Well, I was just thinking in my mind where we should start our implementation. And I'll come back to all of you regarding the sensitization of our students. The students, not only of medical graduate, each and every student who is involved into the care of patient, whether it is allied health group, nursing, or pharmaceutical, whatsoever it is. But before that, now, can I go to Dr. Amitabh Banerjee, our Professor Emeritus from Pune, the public health person? And he is the one you will find his videos very often, perhaps conveying a very important message on a particular topic. Dr. Amitabh, what do you feel about this particular aspect?
Thank you, sir. Thank you, Dr. Agarwal. I am a public health person and I would see the larger picture. And as you rightly said, mentioned about the lady with the lamp, Florence Nightingale. She was the first one to focus on the hospital infections in the military wards. And she did a lot of work. In fact, she's done more epidemiologic work than most epidemiologists. She collected data and found many people were losing their life to hospital infections. Unfortunately, the trend continues today also. The focus is on the best surgeons, best specialists, best consultants, but the nursing staff down, the priorities are less. And actually, the hospital is a very complex system, and every part counts. And perhaps the grassroots count more than the top when hospital infection control is concerned. Recently, only I think last week only, there is a big high-profile case in Pune, liver transplant. Wonderful surgery done, but both the recipient and the donor both died, husband, wife. Very tragic case. And the best surgeons, the best facilities, and it was again due to infection, perhaps. I mean, the inquiry is going on. So we are not, and particularly I have seen in big corporate hospitals, they will hire the best consultants, they will pay them very highly, but the nursing staff downwards are not well looked after, and best of our nursing, competent nurses, they go abroad. And very makeshift arrangement is there for the auxiliary staff, right up to the level of the safai walas, because they are also important in hospital infection control and the safe hospital environment. I mean, there are sometimes fire hazards from time to time. Sometimes I was just seeing, because this dog problem is in the limelight, I was seeing there have been instances every year. We see an occasional instance of a dog carrying away newborn babies. I was just seeing in the web search, 2022 Panipat, a dog carried away a baby. 2020 Godhra and Bankura. So these are because we are not paying attention to the grassroots level. Understaffed hospitals, say people in charge of the security. We may see, particularly in government hospital, dogs, cattle moving around in the veranda. So these are some of the hazards. And as a public health person, I was just thinking, because we have been involved in a lot of factory inspections or food inspections at process. So there is those in public, and I think it's a concept which is there, that is hazard analysis at critical control points. So when the hospital infection for safety is done or audit is done, one should visualize that at any point, there may be a weakest link. What hazard can occur? Maybe it may be a fire hazard. There are instances where patients get killed in fire. There are instances of there is no fire exit, no fire precaution. These are the small things where medical profession misses out and which can cause big tragedies. And similarly, what are the critical control points? Are they, say, stray animals control, or even the visitors, because they carry the hospital infection? And it's a very complex, and I think we require a interdisciplinary from management, from human resource. And of course, medical expertise is one thing, and we are concentrating too much on the top-down approach. We should have a grassroots and bottoms-up approach, increase the staffing, and particularly in government hospitals, there are a lot of vacancies which are not filled, of nurses, of technicians, of other paramedical medical people. So we require the leadership which can identify with the person to the lowest hospital staff, because this is I mean, each one has to play its role, and any weak link maybe at the lowest level can jeopardize the best of procedures, the best of operations. And then besides that, there are the food hygiene and other things. Besides that, there is the quality control of medication. So it's a very vast area. And like Murphy's law, anything which can go wrong, can go wrong. That's all I have to say.
Thank you. Thank you, Dr. Amitabh. I always say one thing, Dr. Vijay Agarwal, that medicine is never 10 plus 10, 20. Sometimes it become 19, sometimes it become 21. But when you say, okay, it can be 10 plus 10, 19 or 21, I don't mind. But once it becomes 10 plus 10, 15 or 25, then you have to really see why it is happening, right? So that is where the entire framework of patient safety is being incorporated. So after having such wonderful discussion, my next question goes, which is perhaps hitting my mind. What is the solution? Awareness? Let me start from basic education. Where are we as regard our medical and any other graduate of any allied health group? Are we teaching them enough? Are we sensitizing them on? Is it the part of their curriculum? They have been examined on it. Vijay, you start your quick comment.
Sir, right, I'll come to your question, but just I had a couple of thoughts on what has been discussed so far. And you said, for example, that Rome was not built in a day, and you said the government is doing its best. So number one, this is a problem which is lying there for 2,500 years, sir. Hippocrates talked about first do no harm. So he must have seen that there was harm at that time. And that's where he came out with that statement. So this is not an issue which is of some years. And therefore, unless or until we change this mindset that we need to act much more decisively and aggressively, I am very sure that this problem will remain for times to come. Nothing is going to change. Second is when we say the government is doing its best, somewhere we are giving them a kind of a clean check so that they have done their part. There is nothing more that they can do. I am sorry. Unless or until the policy makers are also tasked with the task of implementing what is supposed to be the end result of it. So I'll tell you, for example, the newest kid on the block has been the accreditation bodies. And over a period of time, what one has realized is that a body is only concerned about how many hospitals have you accredited, how many people. That is the statistics they are following. They are even following their, profit and loss of the accreditation bodies rather than seeing that what avoidable harm, what medical errors have happened, and how can we reduce it. So, for example, an organization like ours, we have given a call that accreditation is the beginning of your quality journey and is the first step. You need to go towards from accreditation to being accreditation ready on every single day, and then to becoming a high reliability organization. Sir, but what we realize that ये सारी जैसे नकार खाने में तूती की आवाज हो रही है. The people who are supposed to do this, they are not becoming a part of this dialogue. I want that the people who are making, it is very, very fortunate that we have people like Dr. Madan Gopal, but he has been an exception to my mind for a very long time. But let me say that where do you find health secretaries and the health ministers and all that to be a present of discussions like this? Because somewhere along the line, sir, there is a huge gap that they don't have that responsibility of what we are trying to discuss here. I feel that as far as medical education is concerned, another part that you talked about, I would again like to come on the ABDM that Madan Gopalji talked about. It's a huge step that was taken by the government. But look at it, where is it lying? It is just lying like a railway carriage which is lying on the track. It is ready, but nothing more is happening beyond it. because somebody else has to give a push. We are giving incentives to the hospital, let us say for NABH, I'll say rather give incentives to hospitals which have adopted digitization. Because unless or until you do some of those disruptive things, nothing will change. Medical education is, of course, one of the most neglected, and we are teaching things which has no relevance. We are not, a simple question, are we producing doctors who are job ready? Are we having nurses who are job ready? And if this question cannot be answered by the National Medical Commission, what role they have for being in existence? I think if they would have dismantled all that thing, probably you would have made better doctors. I'm sorry I just come out like a activist, but that's what I am, sir. Thank you, sorry.
Certainly, it is not the question of being activist. These are the voices which comes out with your experience, what you observe. And we feel sad, person of your seniority, experience, dedication. And when we find that perhaps we are not achieving that much goal, one even become emotional. So I am with you, Vijay, entirely on this particular issue. Now I'll come back to Dr. Madan Gopal. My question is same. What to do next?
Sir, Dr. Gyani has also joined, just to tell you, probably you missed him.
Dr. Gyani ji. Dr. Gyani.
He was there.
Okay. So shall I start or wait for Gyani?
Let Madan speak.
Meanwhile, we will continue with Dr. Madan Gopal.
Okay, sir.
Dr. Gyani.
Sir, the challenge which Vijay ji has posed is quite pertinent. The challenge is we are to move from policy to practice. That's the biggest challenge. It's not a compliance box to tick, as he has mentioned that only the numbers. We are only focusing on numbers, how many accredited institutions. We have to go beyond that. And it should become a culture of this. So I would be just quickly coming to how we can take the things forward. Because one of the things, if you compare with the OECD countries, wherein the patient safety is taught from day one, whereas we have an optional module in the medical curriculum about the patient safety. That means that's the difference. That means right from day one, as he has mentioned about the Hippocrates, do no harm. That means right from day one, we have to teach our medical professionals, including doctors, nurses, allied professionals, that do no harm. Because I'm just citing an example. We are all pushing for reduction in maternal mortality, the delay. If a facility is not having a facility for conducting emergency operations, what they do? They only refer. So that's the kind of practice is there in the system. We have to see that if I am referring a patient, I should know that if I am referring a patient to an institution, the patient would be taken care. That kind of thought process is not there, sir. That's exactly missing. That means if I'm missing, suppose if I'm sending a patient to you, I know that your center is having that facility and the patient can be saved. But that kind of culture is not there. That means if I'm referring a patient, I should know that the center where I'm referring, the patient can be taken care and can be saved. For the sake of referring, we are referring the patient, and what happens to the patient, that's not. That culture has to be built in, sir. Besides that, what we can do, one, we have to strengthen the reporting system, sir. We have to bring out a culture. That means we are working for the safety of the patient. Even if I'm giving an injection, I should know what is safe for the person or not. The system needs to be strengthened, sir. We have to establish a national patient reporting system, learning and system. That system is to be created. That policy mechanism is there, but we don't have the mechanism for reporting. Capacities, I have mentioned that there's a big area. We have to build capacities of the MBBS, nursing, and the paracurriculum right from day one, not after they have become doctor as an optional module for that. We have to train. We have been doing just lip service in training the nurses for infection control for biomedical engineering and patient safety officer. But it's only lip service. We have institute just checkbox that I have done this thing. Besides that, we have to engage with the patient. See that the patient charters are there in the hospitals, the rights of the patient. They have to begin with rights of the patient in the hospital, what the patient is entitled and what kind of information is required. As Sunila ji has rightly mentioned, even people like us, we face challenges of getting proper information about our own relatives or other persons who are admitted this. If we are facing this challenge, we are having connection, we can talk to the consultant, but where is that patient rights of knowing what is happening, what kind of thing is happening? For the name of patient right, they have a counselor who will just frighten that patient and say that if you don't do this procedure, and the things are will go haywire. Then apart from that, we have to involve the patient representing hospital quality committees. When I visited this Latin American countries, wherein they decide that what kind of treatment modalities, how the treatment things can improve. The patient representatives, they say that okay, this is the best mode for them. And it's a distant dream from us, but at least some of the places we can try that. And besides that, as our highest leadership is always talking about, we have to make a public campaign or movement toward this. See that how, as we have made a public movement around the Swachh Bharat, how we can make a safe care for all, that kind of movement we can build it. To take the patient safety forward, we must combine strong systems, skilled people, smart digital tools, and empowered patients. Only then will safety move from policy into everyday practice. I stop here, sir. Thank you very much.
Thank you, Dr. Madan Gopal. Safe Care Campaign. I liked it. I think we need a campaign like that at the ground, at public health level. And only then perhaps some sort of voices will be raised. And as a part of medical professional, it becomes individual responsibility. But I really wish that each and every part of the medical profession in our country becomes so sincere and sensitive like in front of me. I'll come to Dr. Gyani, but before that, Dr. Sunila, your quick comment on what is the futuristic planning as regards medical education?
Thank you so much for raising this question, because there are now, the system is very proactive and pro-responsive, because we have started with early clinical exposure and family adoption program. When Dr. Madan and Dr. Vijay talked about, the patient safety, and one of the important components they highlighted was patient and family engagement. So that part, these are the important platforms where our students, and we can start right from Maulana Azad Medical College, that when we have early clinical exposure, patient safety should form a very, very important point. And then, we have to build them as leaders. That part is important. So we also have to sensitize them. If there is an error, there has got to be no blame game, and we have to create an environment where they can report the error. So that is where we have to be, kind of be the messengers of change, and with skill-based learning, they can learn about that. And then also when they go to, district residency program, we can, have, that is another opportunity where we tell them, how to do the risk identification, the reporting, and how, evidence-based practices are there with regard to, patient safety. And every time it has got to be an opportunity for capacity building and training. Another part which I would like to say is that every time we have to promote safe use of technology, and we have to implement electronic medical records. And this has to be inbuilt into the student of today, whether he's a medical student, paramedical student, or in paramedical, everything comes in. But right from, I'll say, Ayushman Arogya Mandirs, where we have started talking of digital records. So also in our private sector, that part has to become our culture. And another thing is that when we talk of medication and infection, safety, that also has to be part of our curriculum, and continuous quality improvement through, plan, do, study, act, that PDSA cycles. So when we talk of safe care, that part, has to be integrated into our culture. So we have to have a medical student who is competent, skill-based, and job-ready, and not a blame game student. That has got to be there. Thank you so much.
Thank you, Sunila. A quick comment from Dr. Banerjee.
Sir, as Dr. Agarwal said, the medical education is going off track. And I find I have been a medical teacher for 20 years. the medical students and doctors, young doctors, are the most arrogant. And this arrogance has to go. They do not treat the auxiliary staff well, right from the nursing level. They think that they are superior. And this type of arrogance, and in fact, there have been studies that doctors are also equally, sometimes they miss the basic hand washing and other infection control. And it is the message goes down. So this type of each part of the team, I mean, doctors to be trained as leaders, they have to be, the young medical graduates have to be told that this attitude of arrogance should not be there, and they should be open to any criticism or any sort of alert from, say, nursing staff or the other staff. Sir, you are not washing your hands properly, or you forgot to wash your hands, or so this type of checking among the team and feedback from the team, this could give a culture of benefit to the patient rather than having a hierarchy. I mean, they have done studies in the aircraft safety also. They found when the pilot was taken as the captain, and the other staff will not point out any oversights. So when they change that attitude, that any safety first, even the lowest technician can point out any omission, which may be.
Raise the alarm.
So that attitude has to be there. Here we don't have that courage because of the arrogance top down.
Thank you. I think attitude is very important. That has to be looked into and should be changed. So obviously, before I go back to Dr. Gyani, let me also give one of my experience that when we talk about pharmacovigilance, we talk about the post-vaccine reporting of the complications, etc. And hemovigilance, I remember I was involved and chair of a device which was put inside the body, and later on, after a couple of years, the device reacted, and perhaps many of the patients were having miserable life, and they had to be, surgery was redone. So that gave the concept of material vigilance. Material, so many devices are put inside the body, and that becomes equally important for us to understand what is going to be the long-term effect of that device which is being put inside, and do you think our patient will be benefited in totality, or there may be harm later on? That is, I think, in our list, if we can add also material vigilance like hemo and pharmacovigilance, that will be very important. So now I am coming to Dr. Gyani. Dr. Gyani is the person who is supposed to be the quality person of India, starting NABH campaign, Quality Council of India, and I think now he is president of ASPI, responsible for the overall governance of maybe hundreds and thousands hospitals all over India. Dr. Gyani, will you like to give your experience of implementation of various policies and in what way we can improve upon?
Okay, I think I have heard, except the first 10 minutes I was not there. If you see the fundamental, patient safety comes from where? It comes from policies, and then policies have to be built into number one, if I say, in the education system. Now, recently, if you have seen, when UP government organized the inspection of the nursing schools in UP, the mind-boggling figure of 42% of nursing schools were asked to shut down. That means they were not even good enough to remain functioning. If that is the stage, Dr. Amitabh said about the doctors are okay.
It's
or
unfortunate.
Yeah, but the nursing, he said, very poor shape, and only good nurses go abroad. So that is one. Coming to even about our MBBS, I think you brought me into the academic council, and we tried our best to include the patient safety curriculum into the MBBS, and I think it has taken so many years. When the WHO curriculum is existing, they should have gone right in the beginning in our MBBS curriculum. I don't know why we could not do it. About allied healthcare, which is also very, very important component. I think we have been overlooking this component very badly. In fact, they are the one most of the time along the bedside of the patient, next to nurses. But there is even from 2023, the commission which has been passed in Parliament is still, I think recently only I know that in a month or two, they have started functioning, just functioning. So this is the status, where we have our education system. And reforms in healthcare, they start from the education. So that is the one, the very important aspect. It has to be done. In fact, I was listening about 2 weeks back, a webinar on the stroke. And that the speaker was telling that the intravenous thrombolysis, most of the, neurologists can do it. But when it comes to intra-arterial thrombolysis, hardly 40% of them can do this procedure, which actually is an important one because up to 6 hours we can do it. But when it came to mechanical thrombectomy, he said very little number of, because of course nowadays the interventionists are also coming into the picture, but very little number of them is trained on this one. So I was really surprised that the stroke, we have been talking so much, and we do not have the trained manpower on this very important component. So I think somewhere, again, I'm saying education, training, fellowship is the one. And finally, I will say the patient safety comes number one by the regulation. And we have seen very poorly the, Clinical Establishment Act, the way it has been implemented, rather not implemented. So only way was that through payers, and payers were relying on accreditation. And accreditation, of course, we know that a lot of pluses are there, certain minuses are also there. And third one is that when our community gets empowered, but that I think will take, in my opinion, maybe take another 10 years time, when the community will be able to put pressure on the patient safety related aspect. So I think the policies have this component built in about the regulation, but the implementation is very, very bad. And this, so I think these are my points. Education and regulation only is the way that you can build the patient safety.
Thank you. Thank you, Dr. Gyani. I think ultimately we have to realize that ultimately we are here for the patient. Am I correct? And once we are here for the patient, we have to talk in the best interest of the patient, our society, and in case we are able to build up that particular confidence in society, we will be able to regain the confidence which we are losing or we have already lost. So with this remarks, I will take you back to Mr. Tiwari. Tiwari साहब, आपके पास कुछ questions होंगे हमारे experts के लिए?
Yes, sir. This first question goes to Dr. Vijay Karwal sahab. He's a president Kaho, and I think he might be able to answer this question. Sir, this question comes from Suresh Iyer, Hyderabad, and asking how do we ensure that patient safety policies are just documented but actually implemented at the ground level in hospitals? Should I read again?
No, you are saying that how should the patient safety policies can be implemented at the ground level? That's what I think your question is.
Yes, sir.
So I feel that we have to build on, number one, we have to build on whatever success or wherever we have reached. So let's understand, definitely,
Yes, sir.
accreditation bodies remain an important pillar of promoting patient safety. But Where are the gaps? Why is accreditation not helping globally, not only in India? Let me tell you, the mother of all accreditation body has been the Joint Commission, which has been an utter, not, I will say not utter failure, has been a failure even in a country like United States. So the failure is because accreditation has to be seen as a beginning of the quality journey for every institution, not the end of the quality journey. It has to be understood that the hospital should be promoted to be accreditation ready on any given day, not on the appointed days. So we have to see how do we make hospitals make a journey from being accredited to being high reliability organization. And that journey should be that I am accredited, then I am accreditation ready on any given day. Then I am looking at every department, every function of mine. I'm looking at cardiology, orthopedics, etc. And I have defined that which are my never happening events. How do I make centers of excellence in all those areas? So, and I will say adoption of digitization, for which we require huge amount of governmental push. They already have done the huge work in making the ABDM. We have to make use of it. In this country, we don't even have city-wise, district-wise data of the healthcare institutions, doctors, or anything. As a citizen, I don't even know who are the neurologists in 5 kilometers area within me. How can I connect with them? So today, there are, I will say, you have to look at where we are and then pick up these threads. And people right up to the level of the health secretary, health minister, and many things, they need to understand it is their job to see that how do we make patient safety as a primary thing. So I have said that I'm very fortunate to be a part of this organization, CAHO, which has become now a movement. Please understand today, adjoining countries like Nepal, Sri Lanka, Middle East, Oman, they are looking at CAHO that they want to start a CAHO-like movement within our own country. But here our own accreditation bodies are not, if they would have been joining hands with us, I think we can do wonders.
Thank you, sir. Sir, this question goes to Dr. K. Madan Gopal Saab. Sir, this question from Divya Nair from Calcutta. The question goes to you, sir. She is willing to know, in your opinion, what should be the government's priority in terms of health policy for patient safety in India?
Amresh, this policy intent is already there. We do have a policy in place. The intent is there. Only thing which is required is to make awareness about these policies. You have to make the patient aware about their rights. That's why I have mentioned in my talk as well. That means we should be having patient charters in all those, so that it has to start. As Vijayji has mentioned that it has accreditation is one part. The actual work begins after the accreditation is done. So that means we do have in the public sector, we do have NQAS. In the private sector, we have the NABH accreditation. But where is the patient charter, patient requirement, patient safety aspects? So that's the important question which we should be asking. We have to create an awareness around this patient safety. That means these are your rights. You should be knowing all these things, not the Google-driven thing, because that's a balance which we have to make, not the Google-driven answers, question. Google also tells about the treatment modalities in this, but they will not talk about the patient safety. As I have cited the example that even if you are going to a hospital, the referral and the suggestion which is given to a person, he goes to that hospital, he should be adequately taken care. That kind of confidence has to come into the people. And that kind of confidence can only come when we have a lot of awareness building activities. Beside awareness building activities, we focus on building capacity across all the 3-4 tiers of the health professionals which we are having.
Thank you, sir. Sir, next question goes to Dr. Sunila ma'am. Dr. Sunila ma'am, could you tell us what kind of monitoring or audit system are most effective in tracking the success of patient safety policies?
I think, thank you so much. I think we all, I'll say that the broad framework is that we all aim for a world, where we are looking at every patient receives, safe and respectful care. Now, within this whole framework, when you say that how monitoring is done with regard to different parameters. When we talk of medication errors, when we talk of infection control, when we talk of adverse events following immunization. So for everything, when we talk about, there has got to be regular monitoring, evaluation and all that. But then also we have to have the systematic processes. That means, like, suppose when we talk of hospital infection control, to take a simple example, within the broad framework, initially when we were talking about, I talked about fellowship in HIV medicine. Within that whole thing, micro thing also we talked about कि कितने often आपका fan clean होता है, फर्श clean होता है, labor room के क्या parameters हैं, जिस तरह से हम लेबर रूम को आफ्टर डिलीवरी सैनिटाइज करते हैं, क्लीन करते हैं. सो एवरीथिंग बिकम्स वेरी इंपॉर्टेंट. सो एवरी एस्पेक्ट नीड्स टू बी ब्रोकन एट माइक्रो लेवल, which is already existing. And monitoring and evaluation, all these processes is very important. And this must be discussed in our monthly meetings with our all staff. It's not only doctors, paramedicals, even the group D employee. कि उसने लेबर में जब वो क्लीन कर रहा था, लेबर में उसने रबर बूट्स पहने थे, नहीं पहने थे, किस तरीके से क्लीन किया. सो दैट पार्ट बिकम्स वेरी वेरी इंपॉर्टेंट. सो आई थिंक दैट monitoring and evaluation is the back of looking at all the errors and how there is something known as maternal death surveillance response. हम maternal death की audit क्यों करते हैं? ताकि अगली बार हम उसको बचा सके. Because Dr. Madan made a mention of maternal death. So that part, monitoring and evaluation, is very, very important. Thank you.
Thank you very much. Next question goes to Dr. Amitabh Banerjee Sahab. Sir, this question raising by this Amit Khanna. Sir, could you tell us how can patient awareness and education contribute to their own safety during treatment of hospital stays?
Thank you, Amit. That's a very good question. Patient participation is the actual way forward in modern medical practice. Clear communication between the patient and the doctor, and the doctor should be open to any questions from the patient and give a honest and transparent answer. And the patient can also point out any other hazard, like there is a feedback suggestion book when the inpatient or outpatient, and that should be taken very seriously because patients are seeing the ground situation. Any lapse from any of the staff, like a doctor may come only for rounds or interact for a very short time. So the doctor should be open, or the other staff, they can be other supervisory staff who should be open to any feedback from the patients. And that feedback is very important because that will make the environment safer.
Thank you, sir. I think Dr. Gyani switched off. Dr. Gyani is not able, sir. No issue, sir. This question goes to Dr. Arun Agarwal, sir.
जी बताएं.
Sir, could you tell us how important is leadership commitment in ensuring a culture of patient safety across healthcare organizations? You are an excellent teacher, sir. You could tell us how it's possible.
तिवारी जी, ये तो हमारे जितने कुलीग हमारे सामने हैं, ये भी आपके सामने कन्वे भी कर चुके हैं कि दिस इज पेशेंट सेफ्टी इज ए मूवमेंट. ठीक है, इस मूवमेंट को मूव करने के लिए तो कोई गांधी ही चाहिए ना हमको. तो they have
idle person like you, sir.
No, we all are there. We all are there, and perhaps involvement of younger generations is very important, right? So I'm requesting all my experts in front of me, whenever you are holding your valuable workshop, training workshop, etc., more and more younger generations should be involved, not only as audience, but at the faculty or as a participant into the discussion. And once they get the responsibility, and I agree that the accreditation of any institution should not be for the sake of accreditation. As
Signature.
Vijay said, accreditation should be there for all 365 days. You cannot, I mean, I don't mind recommending or requesting NABS to have a surprise check, like NMC has got the mandate of surprise check. Otherwise, it becomes least important that I'm NABH or I'm JCI, and then my next inspection will be done after 3 years, and we are relaxed. There has to be a particular phenomena, a check, so that I'm alert every day. Every administrator, every administrative person is alert to maintain the quality. And I fully agree that जैसे हमने कहा रोम एक दिन में नहीं बना, बट आई एग्री, हम अपनी जनरेशन की बात कर रहे हैं, यंगर जनरेशन की बात कर रहे हैं. दिस इज द राइट टाइम टू सेंसिटाइज आवर, एंड बिलीव मी, our younger generation is much more intelligent, much more sensitive, provided they are guided accordingly. So it becomes
Thank you, sir.
responsibility of all of us.
And now, sir, I
Yeah,
request
indeed.
you to kindly conclude today's webinar. Hand
And
over to
thank
you,
you
sir.
very much, all my experts. डॉक्टर ज्ञानी जी, देर आए दुरुस्त आए, हमने आपको मिस किया, लेकिन आपने जो अपना कंक्लूजन दिया, थैंक यू वेरी मच फॉर दैट. डॉक्टर विजय, एज यूजुअल, यू आर द मास्टर स्ट्रोक person for patient safety. And through you and your organization, I wish that now the message should go into periphery and periphery. मेरे ख्याल में ऐसे इंस्टीट्यूशन को तो हमें रेगुलेटरी पॉइंट ऑफ व्यू से मॉनिटरिंग का भी अधिकार देना चाहिए. See, there are examples where such institutions are being requested to monitor. And Sunila, थैंक यू वेरी मच. डॉक्टर मदन गोपाल अभी अभी चले गए हैं, मुझे मैसेज भेजा था उन्होंने. डॉक्टर बनर्जी, एज यूजुअल, योर थॉट्स आर वेरी क्लियर. एंड perhaps how to double helical should take it forward. तो एक तो मेरा प्रपोजल ये होगा कि इसमें क्रिस्प रिकमेंडेशन आपकी तरफ से, with the help of all the experts, should come into writing through double helical, as well as some sort of system can be created that we involve our youngsters, nursing youngs, medical, dentist, pharmacist, and now your National Commission of Allied Health Professionals. I wish we should have a dialogue with them officially and tell them कि भाई पेशेंट सेफ्टी की पहले बात करो. कैरिकुलम हम बना रहे हैं, पेशेंट सेफ्टी के should be the first priority. Let us see what happens, and we'll continue our dialogue. Thank you very much, Tiwari ji, for giving us this
Thank you very much.
opportunity.
Thank you very much.
And we'll meet soon. Thank you very much.
Thank you,
Thank
sir.
you,
Thank
sir.
you so
Thank
much.
you.